I'm Peter Block here at AHA at the annual meeting in Chicago, and I'm here for On the Scene. And with me is Bob Mischler from New York. Bob has just presented the enigmatic mitral regurgitation trial as to whether or not it is important to do a mitral valve repair at the time of CABG or not. MR being the enigmatic thing it is. So Bob, tell me about this trial, and we should talk about how difficult this whole area is.
Yes, so this trial looked at patients with chronic ischemic moderate mitral regurgitation, well-defined, methodically defined in 301 patients, randomized to receive either bypass surgery alone or bypass with an undersized annuloplasty ring as part of the mitral repair.
So, in fact, you did a good repair, and this isn't just a sloppy repair, and patients really got the best deal if they had the repair side of this. So the short version, I guess, is what did you find?
Well, we found, interestingly enough, that the addition of mitral valve repair to CABG surgery did not provide a meaningful clinical advantage. It did not reach the primary endpoint of reverse remodeling by a reduction in LV end systolic volume that was significant compared to patients with bypass surgery alone.
Now, Bob, I've had a particular interest because I'm an interventional cardiologist in this area, and the mitral valve is the next big hurdle. So, a couple of questions for you. Number one, this is moderate mitral regurgitation, not severe.
Yes.
And so maybe you wouldn't expect to see an awful lot of difference with repairing that. And then secondly, what about the negative sides of this? You're in the left atrium, surgeons are poking around in there. That can't be all good.
Well, the literature up until this point in time has been variable and inconsistent with respect to whether one makes an impact with bypass surgery alone in terms of the reduction in mitral regurgitation. So this was really a meaningful study and looked at this population of patients, comparing the two, and found that there were higher untoward events with patients who underwent mitral valve repair. Those events were a higher neurologic event rate that was significant, as well as a longer cross-clamp time and bypass time, and thirdly, longer time in the ICU and longer length of stay.
Perhaps no surprise. It's also no surprise that if you looked at the data, as I have, that the patients who didn't have mitral repair had more MR when you followed them up. So at the end of 1 year, there was no difference. What do you think about that outcome, and tell me what you think is actually going to happen to these folks?
Well, it's interesting. At 1 year, the patients who had bypass alone, 70% of them had no trace or mild MR compared to 89% in the repair group. So there was a significant improvement with bypass alone. The converse was important as well. 11% of the patients in the repair group 11% of the patients in the repair group had moderate or severe MR, where it was 3 times as high in the bypass alone group. Now, this is 1 year, and so what's very important is to try and understand whether there is a clinical benefit to having less mitral regurgitation. And so we will study these patients out to 5 years, and we anticipate presenting the 2 years results shortly.
Well, the teaching point here seems pretty clear, Bob, that right now, at least for 1 year, it doesn't make much difference, a little bit of a risk maybe, but I will bet you that when you see these follow-up patients in 5 years, you're going to say, maybe we should wait even longer. Would you agree?
Well, I think you may be right, because residual mitral regurgitation seems to, in many clinical single-center observational studies, be very impactful with respect to heart failure and different outcomes. So I don't know whether it'll translate into a mortality benefit, but it may translate into issues with respect to rehospitalization and heart failure.
And possibly even left ventricular end systolic volume index.
Yes, these hearts may grow.
Thank you, Bob.
Thank you.